So welcome back to the third session, the last session of our meeting. It's about diagnosis and monitoring ILC. And as we learned from Monday afternoon, this is a real issue. Diagnosis and of lobular breast carcinoma. So we have a beautiful program. And Rachel Jankovic and myself are very happy to welcome the keynote lecture number 3, Dr. Pareja from the Memorial Sloan Kettering Cancer Center in New York, and you're going to talk about bridging pathology and AI.
Thank you, Anne. Good afternoon, everybody, and thank you for the kind invitation. I'm truly delighted to be here. I just forgot my pointer. Give me 1 second. I'm really excited about the opportunity to discuss from the eyes of a pathologist, how can we bridge pathology with artificial intelligence, or AI, which is the ability of computers to conduct tasks that usually require human intelligence, such as, for instance, the abstraction or the extraction of information from images and decision-making, which is pretty much what we do as pathologists. This is the outline of my talk. I will start discussing with you the applications of AI in pathology. Then I will review some ILC priority questions that were identified by people here in the audience. I will then share with you some examples of AI-based solutions in the diagnosis and the study of ILC. And I will end this talk discussing emerging AI models and the outlook into what is coming. Computational pathology, which is the application of AI to digital pathology slides, was possible thanks to the progress in many different disciplines, such as, for example, histopathology, which started many years ago with simple H&E slides. Later, they were immunohistochemical stains. Following the description of the DNA structure, molecular pathology emerged with Sanger sequencing and some original techniques. Some decades ago, there was a boom in molecular pathology, including next-generation sequencing, and this continues evolving with more complex and advanced methodologies. In parallel, computer vision, which is the field of AI that can extract information from images, also evolved. It started in the 70s with some simple algorithms. Then there was the emergence of convolutional neural networks, and nowadays this has evolved into very advanced, very complex methodologies. And this is how the parallel evolution of these fields shaped computational pathology as we know it. And now I want to share with you the evolution of a pathologist. To generate these slides, I got some AI help. I used an AI tool prompted by ChatGPT. It starts with this random pathologist on a Monday that has a couple of slides, has some cases, very manageable workload. She finishes her cases, is reading some interesting papers, and preparing a talk, for instance. Completely anonymous pathologist. A couple of days later, after 2 days of service, the tension starts to mount. She has more cases, she has to evaluate margins, she receives some phone calls, she has to quantify some ER and HER2. Still things are okay and manageable. By Friday, although she's still very composed, there are many tasks that this pathologist has to achieve. Not only she has to diagnose all these cases, classify these tumors, go over these lymph nodes, go over all of these margins, she also has to report ER, PR, HER2, PD-L1, Ki-67, she gets a phone call from an oncologist, can do quantify TILs, of course. Then she has to go over this very long list of genetic alterations and identify which are actionable, because she has to present them a tumor board to help the clinical care team to tailor therapy for the patient. And she could use a bit of help, perhaps from AI. She could perhaps start to incorporate these tools that little by little are being developed and slowly but surely are being incorporated in our practice to automate some of these tasks. She could use some tools, for example, to assist with the screening of lymph nodes to detect nodal metastases. She could not only use these tools to reduce the burden of workload to automate tasks, she could also potentially use all of these more advanced tools to predict, for example, molecular alterations or biological processes from H&E slides, and this way provide extra value to what we can extract from a pathology image. And this is how the evolution of these pathologies goes, perhaps from right to left. There are several applications of computational pathology in diagnosis and in research. In diagnosis, for example, one can automate several tasks that can not only reduce the burden of workload, but that can also increase reproducibility. One can also, for example, infer molecular alterations that could help us tailor therapy. Of course, all of these applications have to undergo validation before being deployed. In terms of research, there are many things that AI can do. Just few examples. Detect genetic alterations, not only genetic alterations, but also predict gene expression, perhaps assess heterogeneity, and many others. Perhaps AI can help us close some gaps in ILC. So I want to discuss this very nice work that was led by Steffi Osterreich and Christine Desmet, and many of you present here in the audience, where researchers, clinicians, patients, and patient advocates got together to determine which are the ILC priority questions. And they ranged from epidemiology to translational research. There were, and these efforts were actually conducted by many people here in the audience, such as this study here, where AI was used to predict the risk of breast cancer, where Stuart Schnitt participated. Or this other beautiful study, where AI tools were used to detect tumor from pathology slides to conduct tumor diagnosis, where our department and Eddie Brogy and many others also took part. We have this very recent study where AI tools could be used to predict response to immunotherapy. Of course, many of these studies were not conducted in ILC, were conducted in breast cancer or in other disciplines, but this shows how AI has the potential to be applied to ILC. AI has also been applied in radiology. And finally, AI can be leveraged for more basic or translational discoveries. And it is not by chance that many of these AI efforts use as input pathology images. Because even though the pathology slides are very little, they contain an enormous amount of information. And computational pathology is very active in breast cancer, in the breast field, which is terrific. And little by little, all of these research efforts are slowly being translated into tools that could be applicable, that following validation could be deployed in diagnostic practice. This transformation of computational pathology is thanks to enormous progress in different aspects, such as immense progress in AI approaches, also the enormous increase in computational power with decreasing costs. We have also an evolution of the cohorts that are used for AI efforts, It started with single institutional cohorts, and now we have multi-institutional efforts that have not only one type of data, but an array of kinds of data, and even public efforts accruing these cohorts. We have also an evolution in the kind of data that we use. This field started with ROIs with small amounts, regions of interest that were being studied. Now we use whole slide images. And now in the future, the field is starting to accrue perhaps whole slide images across time. And even 3 efforts to conduct 3D analysis are being initiated. In terms of AI approaches, these current models that are fantastic, these are the single-purpose models that are trained using a ground truth, where one provides these models with labels. And one trains these models, fine-tunes it, tests it, then validated in an independent cohort. Once one is happy with these results, one can deploy this model. If one is not happy, one can retrain the model again. And new generation of models are emerging, such as these wonderful foundation models, which do not require labels for training. They are self-supervised, they are trained with an immense amount of data that is very heterogeneous. And this broad exposure to different kinds of data makes these models very robust, that can later be fine-tuned to conduct different tasks. And finally, we also have multimodal systems that use not only one type of data, such as pathology images, but that can use different types of data, such as pathology images, imaging, like radiology, genetic data, and others. Following integration of these different kinds of data, these models can be trained to perform high-level tasks, different kinds. I want to share with you a couple of these beautiful single-purpose models that we are now using and that perform really well, that might be relevant for invasive lobular carcinoma. Some of these models have been used for the detection of homologous recombination deficiency in breast cancer, that, as we know, is the inability of a tumor to repair DNA double-strand breaks in an error-free manner. This is usually caused by molecular alterations in HRD genes. The most famous ones are BRCA1, BRCA2, but we have a very long list of HRD genes. Although HRD has been usually associated with other histologies such as ductal carcinomas, metaplastic carcinomas, there is evidence that a subset of lobular carcinomas have also HRD. And indeed, germline BRCA2 alterations have been associated with lobular carcinoma. Why is this important? Because detection of HRD can help us tailor treatment, given that these patients can benefit from certain therapies, such as PARP inhibitors. And there have been wonderful efforts to predict HRD from H&E slides. One of these efforts, led by Anne Salomon and her team, where they robustly were able to predict HRD in luminal breast cancers, and this cohort included a couple of lobular carcinomas, in a robust manner. Not only this tool was able to predict HRD, they also looked into which were the features predicted by the model and could identify some histologic features associated to HRD and to homologous recombination proficiency that can inform pathology. This is another ILC study, also led by Anne and her team, that was on the development and validation of this very powerful algorithm, the Gallen-Breast algorithm, that was trained in a very powerful manner using a histologic ground truth, following the review by experts pathologists. And this algorithm not only could detect breast cancer, could also discriminate, distinguish, classify lobular carcinoma from ductal carcinoma, which, as we have heard during these days, is very important. The take-home messages of this first part of my talk are that the coevolution of various disciplines shaped computational pathology as we know it, that AI has an array of applications in diagnosis and in research, and that it holds promise to tackle unmet needs in ILC. Now, as Patrick beautifully shared with us or explained to us, ILC is a strong genotypic-phenotypic correlation. Thanks to seminal efforts by Patrick, Christine, and many others, we know that ILC is underpinned by inactivation of E-cadherin, by the alterations in the cell-to-cell junction. A large percentage of ILCs have genetic alterations in CDH1, mostly in the form of CDH1 biallelic mutations that, of course, translate in a dyscohesive phenotype that is the hallmark histologic feature of lobular carcinoma. So we asked ourselves a couple of years ago, can we leverage this ILC genotypic-phenotypic correlation and develop a genomics-driven AI-based diagnostic model for ILC? And then, can we use this model to learn something about the molecular underpinning or the biology of this entity? So this is what we did. We accrued this large cohort of breast cancers, including lobulars, ductals, and other histologies that had been previously subjected to paired tumor normal targeted sequencing using this FDA-cleared targeting sequencing assay that we have in-house. All of these cases had been, of course, digitized. We had the genetic information, and we had the CDH1 mutational status of these cases and LOH information. So we trained this algorithm with a genetic ground truth, which was the presence or absence of biallelic CDH1 mutations. And then we evaluated the performance of this algorithm in terms of detection of this genetic alteration and in terms of diagnosis of ILC. Very briefly, what was the workflow? Whole slide images were used as input, which were partitioned into these very small tiles, which were fed into this breast cancer feature extractor that had been previously trained using over 50,000 whole slide images, and that could help discriminate invasive carcinoma from in situ carcinoma and premalignant lesions. It had as output prediction scores and embedding vectors. So we used those embedding vectors that had scores that were predictive of invasive carcinoma. And we used them as input for this second layer, which was the CDH1 mutation predictor. That was this model that we trained using a tenfold cross-validation system, a train, tune, and test set, and that gave us some inference probabilities that allowed us to determine whether a case had CDH1 biallelic mutations or not. So how did the algorithm do in terms of detecting the presence of CDH1 biallelic mutations? It did really nicely. You can see here, I hope you can hear me. Okay, the green areas here are the areas that the algorithm predict to be mutant. So, and here we can see how the algorithm predicted the presence of CDH1 biallelic mutations in a robust manner with a very good AUC, also high sensitivity and specificity and very nice metrics. There were, however, these cases that we call false positives. These were cases that were predicted by the algorithm to have a mutation, but according to our targeted sequencing data, were not mutant. We thought this might perhaps constitute a wonderful opportunity to learn what is the molecular underpinning of these cases. So we subjected these cases to some epigenetic and genetic studies. First, we assessed the CDH1 promoter methylation status in these cases using a digital droplet PCR assay that we implemented that evaluated the methylation of two key CPG islands in the promoter of CDH1. And we observed that a large subset of these cases had CDH1 promoter methylation associated with loss of E-cadherin expression, showing how CDH1 promoter methylation might be prevalent in lobular carcinomas that lack CDH1 pathogenic mutations. We also conducted the reanalysis of targeted sequencing data, and we observed that some of these cases did not have mutations in CDH1, but had other genetic alterations, such as, for example, homozygous deletions in this case, where both alleles are gone, or intragenic deletions of CDH1, where important exons of CDH1 that encode for key domains of the protein are deleted, and this was associated with LOH of the wild-type allele. And we had a fascinating observation that a subset of these cases had non-coding genetic alterations in CDH1, also associated with LOH, illustrating how, or rendering further support to the notion that ILC is a convergent phenotype that is underpinned by various molecular mechanisms. We also had the unique opportunity to conduct whole genome sequencing in some of these cases, such as in this very nice classic lobular carcinoma with a very discohesive morphology that did not have CDH1 genetic alterations as per targeted sequencing and did not have a CDH1 promoter methylation. And that was very nicely detected by the model, as you can see in green. And when we saw the whole genome sequencing data, we were initially a little bit disappointed because we didn't find genetic alterations in other genes involving cell-to-cell addition, such as alpha-catenin, for example, or many of these other cell-to-cell addition genes. But then we saw that there was a translocation between chromosome 13 and 16. So we got a bit excited because, as you know, CDH1 sits in the chromosome 16. And when we had a closer look at this, we observed that this translocation resulted in this deleterious fusion that led to the loss of the first two exons of CDH1 and this important regulatory region, including the transcription start site, and was associated to LOH. And this was probably the molecular explanation of why this case had a lobular phenotype. And this shows how this AI model could actually detect CDH1 inactivation regardless of the molecular mechanism. Or taken together, our analysis of these false positive cases showed that a subset of these cases have alternative mechanisms of CDH1 inactivation, such as promoter methylation, homozygous deletions, intragenic deletions, novel deleterious fusions, and also intronic mutations. And this illustrates how AI tools trained to detect a genetic alteration could help us decipher novel biology. Lastly, we ask ourselves, can this model that was trained using a genetic ground truth diagnose lobular carcinoma? And it diagnosed lobular carcinoma pretty well, with a great area under the curve and very nice metrics. But now, this time, we saw a set of false negative cases. These were the problematic cases. So these cases were not detected by the algorithm, but according to our pathologic diagnosis, these cases were lobulars. So we had a closer look at this cohort of cases and saw something really interesting, that in contrast to the true positive cases correctly classified that were mostly classic lobular carcinomas, these false negative cases were enriched for histologic variants of ILC and for mixed tumors, such as these cases that we have here, including this pleomorphic lobular carcinoma, not detected so well, this solid ILC, and then we have this mixed ductal lobular, ductal on the left, lobular on the right, and this carcinoma that has lobular components and mucinous components. And in these two cases here, you can see on these detection heat maps how the algorithm could still discriminate the lobular areas from the non-lobular regions, showing how on the same slide this algorithm could detect ILC. And this illustrates the point how this genomics-driven model could diagnose a histologic entity. As we were discussing yesterday in the breakout session, these AI tools sometimes are perceived as black boxes. They are trained, but we don't know what the algorithm is detecting. But one can open this black box and understand the features that, or try to understand which are the human explainable, at least, features that the algorithm is picking up. And when we conducted this exercise, we saw that the algorithm was picking up some characteristics that we as pathologists use to diagnose lobular carcinoma: single cell files, certain nuclear grade, and several other features. And it was picking up also other characteristics that have been described that perhaps we don't think about so often, such as certain characteristics in the stroma, for instance, or in the amount of immune infiltrate in these tumors. And would this be all the features that were detected by the model? Probably not. There are probably some features that when we conduct this reverse engineering, the human eye cannot detect, or that we can detect but cannot verbalize. But this shows how opening these black boxes can inform us pathologists. The take-home messages for this part of the talk is by training an AI algorithm using a genetic ground truth, one can diagnose a histologic entity, such as invasive lobular carcinoma. The genotypic-phenotypic correlations can be leveraged by deep learning methods applied to H&E slides, and that an orthogonal genetic ground truth can be used to develop novel cancer classification systems. To end this talk, I will briefly go over the emerging technologies in AI, such as foundation models, which are these new robust methodologies that, as I told you, are trained not with slides of only breast or only lung, but they are exposed to a lot of different data, slides from lung, brain, heart, adrenal, muscle, tumor, non-tumor, benign. And this wide exposure makes them very robust, and they can have many different applications. Of course, they are resource intensive, and they have a black box nature, but they can have conduct different tasks, such as diagnosis, prediction of genetic alterations, prediction of prognosis. And given their robust initial training, they might require reduced additional training, and they can be scalable and generalizable. This, one example of these foundation models was just published a couple of weeks ago, where this foundation model was able to conduct many tasks, pan-cancer, such as tumor detection, detection of genetic alterations in different organs, including CDH1 in breast, and this model was also able to predict survival. Now, our colleagues in radiology are also conducting formidable efforts to enhance the powers of radiology using AI, including efforts in invasive lobular carcinoma, such as recent efforts from our institution to improve the detection of small invasive lobular carcinomas using imaging and AI. Why do I bring imaging? Because now we have the emergence of these multimodal systems where we can have the input not only of one kind of data, but of different types of data, such as pathology, imaging, genomics, perhaps gene expression, notes from the oncologist, text, and these kinds of data can be integrated, and these robust models can be trained to conduct complex tasks, such as prediction of outcome, for instance. In conclusion, AI is revolutionizing diagnostic pathology. Integration of AI and genomics can help us uncover novel molecular mechanisms. Of course, AI is not perfect. It's still being developed. It requires validation, and there are many hurdles to overcome, not only technological, but also regulatory, cultural, and many others. And of course, collaboration is essential. And in my acknowledgement slides, I want to illustrate the kind of collaboration that one requires. You can see here I have pathologists, medical oncologists, radiation oncologists. There is collaboration across different institutions. Not only that, but there is collaboration between academy, industry, and this is what can drive efforts. With that, I want to thank you all for your attention. I want to thank funding institutions, LBCA, and of course, patients and patient advocates that are always a source of inspiration. Thank you all. I'm delighted to take questions. I don't know if they're now or later. later.
Thank you very much. I think next we're going to have Dr. Dressen from KU Leuven for whole body diffusion weighted MRI. Oh, there you are.
Hello, everyone. Thank you for the kind introduction. Thank you for inviting me, for being here. It's really an honor for me to talk to you about the role of whole body diffusion weighted MRI in lobular breast cancer. So, as you all know, lobular breast cancer accounts for about 15% of all breast cancer patients, and it is most of the time severely underrepresented in many studies. However, it has clearly different clinical, histological, and biological behavior. So it's really important to focus on this specific type of breast cancer. Up to 35% of the patients will develop metastasis with 5-year survival rates ranging between 15 and 50%. And we know that distant staging is very challenging. That is because it has a very infiltrative, most of the time non-destructive growth pattern. And apart from the usual suspects like the liver and the bones, it also metastasizes to the peritoneum or the gastrointestinal tracts or the leptomeninges. So that can be quite challenging for different imaging techniques. And we know that CT, bone scan, and sometimes also PET-CT are not good enough to evaluate these metastases. Furthermore, also prognostic biomarkers and histological subtypes may not be accurately reflected by biopsy, and hopefully, maybe on the imaging, there is more information behind the images. And who knows, maybe whole body diffusion weighted MRI can be of help in this specific subtype of breast cancer. There are a lot of advantages of the use of whole body MRI. It is a one-stop imaging technique for both local, regional, and distant staging. And it combines detailed morphological and functional microstructural tumor information. In many cases, it's more accurate than bone scan CT or sometimes even PET-CT. And apart from the standard visual assessment, we can do image quantification. However, it also needs a really specialized training, and the results might not be that reproducible. Because there are a lot of images, it might take some time to evaluate all these images. Yeah, sometimes the metastatic sites are quite small and not that easy to see. Also, a very important thing is the availability. We are the lucky ones in our hospital who have the whole body MRI, and we use it very often. But also, like I heard the last days, that's not the case in every hospital. So let's go forward on that. This is a very nice paper that was released this month. It is a very nice overview on how and why and to use the whole body diffusion weighted MRI. As you can see, there is a whole list of indications for several types of malignancies. But if we zoom in on specifically breast cancer, then we see that the whole body MRI is better than bone scan and CT, and might even be better than PET-CT. And as a practical recommendation, they say that it is specifically helpful in lobular breast cancer patients and when you need to do the detailed evaluation of liver and bone disease. So how do we do it in our hospital? This is our protocol, where we combine the diffusion weighted images with anatomical images. The diffusion-weighted images are very sensitive to tumoral lesions because they suppress all the signal from the normal background. So that will become dark, and the only thing that lightens up are the tumoral lesions. Of course, there are also some benign lesions with high signal, but you have to do it a lot and learn about it to make the differentiation. But that is not enough. We also always have to correlate it with the anatomical information. The advantage of this technique is that it doesn't require any intravenous contrast. It can be performed on any MRI scanner. Any vendor can have the same quality. 1.5 or 3 Tesla, they all perform very well. And the technique takes about 30 to 38 minutes to perform. In our hospital, we use the whole body MRI for lobular breast cancer in cases of locally advanced disease, as they have a high propensity for distant metastases, sometimes during treatment evaluation for response assessments, and sometimes when you have a clinical suspicion of a recurrence. But for the sake of time, I will mainly focus on the primary staging. For the primary tumor evaluation, of course, we are in a situation where the patient has a known breast cancer, so the patient already had their local imaging, like the mammography, ultrasounds, breast MRI. So we don't want to compete with those local imaging techniques. However, the primary tumor is, of course, also on our images, so we also look at that. And then we perform about the same. Sometimes we can see a little more advanced disease or some multifocality. But yeah, also always good to have a look at the local situation. For the nodal metastases, because of the large field of view, because we see the whole body, of course, we don't only look at the axilla, but also the other regions like the supraclavicular or other distant lymph nodes. And we actually do the visual assessment of the combination of the diffusion-weighted images together with the T1-weighted images. And we look at every region and compare the lymph nodes in that region. So sometimes one of the lymph nodes really pops out, and that makes it really suspicious. We are not there yet that we have a really cutoff of the ADC levels, but hopefully in the near future we will have some ADC quantifications. And also what we think is very helpful is the image on the T1-weighted images, where we, as in the examples below, we can differentiate the benign and the malignant lesions. This is a recent study that looked at the comparison between PET-CT and PET-MRI for nodal metastases, and both for axillary lymph nodes or lymph nodes at other distant regions. PET-MRI seem to be a little bit better. However, these are very small number studies, so we need to be a little bit careful about those data. Here's another review about several studies that have been performed in cervical cancer, for example, and there are a little bit varying results. Lymph nodes remain a little bit a difficult issue for radiologists, but hopefully we will get better and better at it. So for the distant metastases, we know that for the evaluation of bones and livers, that MRI is the imaging technique of choice to do optimal evaluation. And also for those locations with a diffuse infiltrative metastatic disease, like the peritoneum or metastases along, for example, the ureter, MRI is very well at that. So let's use the MRI for that. Of course, lungs might be a problem for the whole body MRI, but in lobular cancer it occurs a little bit less frequent than in other cancer types. And there was one study who looked at the performance on a patient-based level, and then it was about the same for the CT. The thing is that when the lesions become smaller than 1 centimeter, it might be a little problematic. Here is a recent study that showed that compared the whole body MRI with the PET-CT, with the PET-CT being the reference standard. So if it could reach up to the performance of the PET-CT, and we see that the accuracies, not only for the lymph nodes, but also for distance staging of the chest, the liver, and the bones, it reached accuracies of far above 90%. Another review on the added value of the whole body MRI in metastatic lobular breast cancer, specifically looking at this patient population, and they concluded that there really was an added value in the management of metastatic lobular breast cancer, mainly by the detection of additional disease sites and earlier detection of disease progression, which might lead to a change in management, and it might potentially be more accurate than CT or FDG PET-CT. Here's an example of a patient that was referred to us who had PET-CT in a different hospital, and at least on the report it said that there were only 3 bone metastases and no other metastases at any other site, so it was probably or possibly still in the oligometastatic setting. But then we performed the whole body MRI and we found more than 15 bone metastases, and that are not shown on this image, but what we see is in the liver there's a lesion that is very suspicious of a liver metastasis. So the patient actually progressed on imaging from oligometastatic to diffusely metastasized disease. Another example of a patient with a very locally advanced disease with diffuse infiltration of the breast and also the skin with very many and very large axillary lymph nodes, but on the whole body diffusion MRI we also found lung metastases and very many bone metastases, and also a lot of retroperitoneal lymphadenopathies. Here is the thing that whole body diffusion weighted MRI is particularly good at, where it really exceeds the performance of the CT, and that is in the evaluation of peritoneal disease, with a very high accuracy to detect multifocal serosal involvement of the small and large bowel, with accuracies of about 90%, and that are most of the time the regions where CT really struggles to identify these disease locations. With that in mind, we had a retrospective review of our own data between 2017 and 2023, where we compared the standard conventional imaging, like for the local staging, mammography, ultrasound, and breast MRI, with the conventional staging that was decided upon by the multidisciplinary team meeting at that time, and that could be a PET-CT or chest X-ray combined with ultrasound or SPECT-CT. That was a little bit heterogeneous because it was retrospective. And then we compared that to all those conventional stagings combined with the whole body MRI. So for the local regional staging, it was particularly interesting that the whole body MRI was a little bit more sensitive for the detection of contralateral breast tumor involvement. And for the lymph nodes, we saw that also the sensitivity really elevated with the use of the whole body MRI, and which is many times also very important, that if we didn't see any suspicious lymph node on the whole body MRI that we were quite sure that there wasn't any. So a very high negative predictive value of nearly 99%. Here's an example of a patient who had an ultrasound of the axilla, and there was some nodular thickening of the cortex. The patient had a fine needle aspiration, but it came back negative. However, on the imaging, it was very bright, as you can see, and it was also confirmed at the final pathology that there was a positive lymph node in the axilla. But furthermore, there was also a positive lymph node in the supraclavicular region. For the evaluation of distant metastases, we also saw that the sensitivity really increased to 98%, and the accuracy was very high, with nearly 97% in our own population. Here's an example of a patient who underwent a PET-CT for distant staging. It didn't really show any increased uptake, for example, in the bones. However, on the whole body MRI, we had diffuse bone metastases throughout nearly the whole axial spine. Another patient on which the PET-CT found only one bone metastasis, but the MRI found many more bone metastases, so it's a very sensitive technique. Of course, that are very promising results, so we need to keep on with this research, and we luckily we were able to get some funding for a new project, and that is a project where we want to develop an AI-driven quantitative algorithm for whole body diffusion weighted MRI to improve staging and prognostication of invasive lobular breast cancer. And that, of course, is a collaboration between very many different departments. And we want to progress on our initial findings, and we want the computer to aid us in the automated detection of the tumoral sites, and then also extract important information from these disease locations. And hopefully, we will be here another time to present these data. Of course, I know that we are still facing some challenges with the use of whole body diffusion weighted MRI. Mainly, I think it's about the availability. Furthermore, it's also about the acceptance, not only by patients and radiologists. So many images I have to look at. Also healthcare providers in terms of reimbursement, for example. Maybe it's not really widely known, so hopefully you will spread the message. It really needs a lot of expertise from the radiologist as well, because, for example, I'm actually an abdominal radiologist, but I need to go outside of those boundaries to do the whole staging of these patients. Furthermore, because of the large bulk of data, you might sometimes miss some lesions or have some incidental finding with which you need to go further. Luckily, and even moreover, we can get some software support, for example, for computer-aided detection or quantification of the total tumor burden, or extraction of other quantitative information. This is really helpful, but it also makes the technique far more complex. So I hope I convinced you that whole body diffusion weighted MRI is a very promising tool for the evaluation of lobular breast cancer patients. It is really pivotal to do the multidisciplinary team meetings and to stay in contact with all the different disciplines to optimize and individualize the patient management. And hopefully many more interesting data are to come. Thank you for your attention.
Thank you very much. That was excellent. I think we're going to still hold questions till the end. So next we have Dr. Matthew Covington from the Huntsman Cancer Institute in the University of Utah. talking about current and future PET modalities.
Thank you so much for having me. This has been just a fantastic meeting. I've learned a lot. I hope everyone else has as well. And I'm glad to be able to talk on PET imaging today. Let me figure out. Okay, there we go. And then the pointer. Okay. For those of you who were at the imaging session yesterday, there's a few repeat slides, but I've tried my best to not make this too repetitive. On the other hand, for those who weren't there, I still want you to receive a lot of the same message as what we spoke about yesterday, so I'll do my best. I have a few disclosures. I'll be talking clearly about what's research and what's standard of care in this presentation. And first, when we're talking about PET-CT for breast cancer, historically we've assumed that PET-CT means FDG. When I was a trainee in nuclear radiology, really all I was reading was FDG at that time. Frankly, the job was a lot easier then. It was much easier to just keep track of one type of PET scan and just have that be your day-to-day. In the last 10 years, we've made a lot of advancement. In the next 10 years, we're going to make even more. That's the direction we're headed. With FDG, what we're looking at is metabolic activity. And at the time, it seemed that that was really sufficient for most cancers. This was viewed as an extremely great test for nearly all malignancies, was kind of the general thought. And then as time has gone on, we've realized more and more that metabolic activity is only one thing that cancer does. It's only one way that we can image disease on a PET scan. And we're now able to image other processes with PET scans, which I'll talk about shortly. According to the NCCN guidelines, which are pretty influential in terms of staging, but they're not the only guidelines that exist, FDG PET-CT may be used, and I always find it's interesting, they say as an option to CT chest, abdomen, pelvis with bone scan, as if the CT chest, abdomen, pelvis, and bone scan should be the default, and PET-CT is like kind of an afterthought, like, well, if you want to, you could. We know that FDG PET-CT in most settings is much more sensitive than CT chest, abdomen, pelvis with bone scan. On the other hand, it's maybe not as accessible, and even in the United States, we have a lot of insurance denials for requests for FDG PET scans, and that plays into the situation of why a clinician may choose one over the other. Honestly, at our center, I hear a lot of from our oncologists and surgeons that they typically will go with whichever one will get them the result faster. And very frequently that's CT with bone scan. There are indications beyond staging, so initial staging of breast cancer. We also use FDG PET-CT to follow therapy response. We also use it to restage if there's a disease recurrence. We know specifically with breast cancer, as has been mentioned many times here, that FDG PET-CT is less sensitive for lobular carcinoma, as well as low-grade invasive ductal cancers. And the reason why is those cancers take up less sugar. Okay, they have fewer glucose transporters, they take up sugar less. FDG is a radioactive sugar, therefore less uptake, less signal, harder to see. It's no longer just about FDG PET in oncology. Any day I'm on the nuclear radiology service, I'm reading a variety of scans, not just FDG PET-CT. And these are the current US FDA approved radiopharmaceuticals that are listed on the left. And there's a few interesting things about this. Here's FES at the top. This has been approved for a few years now. We have 3 versions of dotatate or DOTATOC. This is all somatostatin receptor imaging. It's mostly used for neuroendocrine tumors, but stay tuned. There might be some use here for breast cancers. PSMA is mostly used for prostate cancer. We also have 3 varieties of that. Each one of these varieties images a little bit different than the other, which adds to the complexity of what your nuclear medicine physicians are doing on a daily basis. Because on any given day, I may get images from a few different PSMA agents, and I have to know how each one looks. Sodium fluoride is approved. That's basically a PET version of bone scan. It's rarely done. And then we have some others that were mostly for prostate cancer. This list is going to expand. I expect and predict, if I have a crystal ball, I would say that the list will rapidly expand, at least according to historical norms over the next decade. We have other potential roles for PET in oncology, and this is all pertinent for breast cancer as well as many tumors. So one is to not only look at metabolic activity, but now to define receptor status. The one that's best known, because it's the one in current clinical use in several countries, is estrogen receptor PET imaging with fluoroestradiol PET. We also have approved agents that look at receptors, so somatostatin receptors for neuroendocrine tumors, PSMA receptors for prostate cancers. We can do PET, and honestly, these tracers aren't exactly new. They just haven't reached clinical approval yet. But for example, we can image HER2 receptors with trastuzumab. There's been a lot of nice work that's been done by Dr. Dadashti at WashU over many years on that. FFNP PET can image progesterone receptor. I believe the LBCA recently funded a PET project that uses FFNP PET. You can also image androgen receptors, which may in the future be found to have some use for breast cancer as well. You can also target, using PET, receptors or other targets for nuclear-based therapy, so targeted radiation therapy. We currently do that in the clinic with 2 agents. One is dotatate, the other is PSMA. Both of these use lutetium, and lutetium has particles that come off of it. So unlike the radioactive fluorine that we use with an FDG imaging study, where the radiation simply passes out of the body and then we can detect it, with lutetium, this is more energetic and larger particles that actually damage DNA, damage cells, locally kill the cells where this goes. And so first you use the PET to identify is the target there, and then through an IV injection, you inject the lutetium version of the same tracer. It will bind to the sites that you saw in the PET scan, deliver local radiation, and treat those cancer cells. That is in widespread clinical use. This is gaining a lot of steam for neuroendocrine and PSMA cancers, and as I'll show you in a minute, they've proven that this works, and now big pharmaceutical companies are looking to expand this to many cancers. Breast cancer is very high on the list of cancers they're interested in treating the same way. We can also assess disease transformation and dedifferentiation. Let me explain that a little bit further. And this is pertinent to breast and many cancers. But basically, a lot of these new receptor-based agents image cancer when they're well differentiated. That means before they've transformed into cells and have receptor profiles that look foreign to where they started. So for example, breast should have some estrogen receptors. A well-differentiated breast cancer is ER positive, as you know. And as the disease progresses, eventually one might lose the estrogen receptor and it becomes ER negative. That has pertinence potentially with PET imaging, because something like FES should bind to well-differentiated breast cancer that's highly ER positive. As the cancer progresses, if it progresses, and you lose the estrogen receptor, what we're seeing is that the FES signal will go down, then the FDG signal goes up. Because dedifferentiated cancers, like FDG, they're very metabolically active. We see the same shift with prostate cancer. You go from well-differentiated PSMA avid, meaning you can see it on a PET scan cancer, and as the disease progresses, eventually you can no longer see it on a PSMA PET scan, and you can often start to see it on an FDG PET scan. There's actually been a number of papers in breast cancer with FES, where they look at the FES to FDG ratio. You compare the uptake on both scans, and how that ratio seems to correlate with things like tumor grade and potentially things like progression-free survival. So as the FES signal goes down, FDG signal rises, you can predict that this cancer is progressing. It might be more biologically aggressive. So here's how these FDA-approved agents look, and you notice that they each look different, okay? FES is right here, FDG is right here, and then we have other agents in between. The importance of this is simply to have some appreciation that each agent is unique, and what that means is each reader of each agent has to be very familiar with the pattern of uptake for that. So expertise does matter with PET imaging, and it's going to matter even more as we go forward. So how many potential PET tracers are under development for breast cancer? This is a evaluation of clinicaltrials.gov, which has most clinical trials registered for many trials in the US. And worldwide, actually, a lot of multinational trials are registered there as well. This is unpublished. This is actually only a few weeks old that I saw this. But what we did is looked at every trial that's currently registered for breast cancer that uses PET, and then we looked at what radio tracer they're using. And you can see there are many PET tracers under study. So again, for me to say that PET imaging is moving quickly beyond just FDG for breast cancer, I think is true. Here's FES down here. It does have the most studies currently by far. But there are other interesting tracers on here as well. HER2 receptor, here's FAPI, which I'll talk about in a minute. Many potential options under study. Here is FAPI, sometimes it's FAP. This is fibroblast activating protein. And this is a different way of looking at cancer that seems to have less uptake with things like inflammation or infection, which is a weak area of PET scans with FDG. And you have somewhat subtle yet detectable uptake. In this case, this is a published case of invasive lobular carcinoma. This is a recent publication from June. And they're showing here that you can see uptake of this gastric involvement, stomach involvement of lobular carcinoma. You can also see peritoneal disease. You can see other disease where the FDG didn't show this. They have an arrow here at benign colon uptake. So fibroblast activating protein may be helpful for lobular breast cancer. We need to do the studies to find out particularly how helpful. Again, theranostics, I've kind of talked about the concept, so I'm going to go through here fairly quickly. But the point is that breast cancer theranostic trials are underway. And in fact, it's possible that we might be able to use these currently approved agents for other cancers with certain types of breast cancer. This is a big question right now, that even a lot of the larger radiopharmaceutical companies are currently asking themselves, can we use somatostatin receptor-based therapies for breast cancer? It turns out, if you Google, which I initially did the first time I heard this concept, whether breast cancer expresses somatostatin receptors, it turns out a lot of breast cancers do. The same might be true for prostate-specific membrane antigen, which is funny because the name says prostate-specific. It is not very specific to the prostate. Many cancers have PSMA receptors, including certain breast cancers, more commonly, based on what we know now, triple-negative tumors. Let's move on. So this is the current landscape of development of theranostic agents in the US. This is all cancers. Well, not US, worldwide. Many of these companies are European. And we have the 2 approved agents in here, and then all of these other dots and stars and squares are agents under current development, from preclinical all the way to phase 3 trials. And this was in May, and this is a very similar from this month. And to me, this looks a little busier. And if you actually count what's going on, you get this. And actually, in the last several months, the number of registered preclinical trials has increased from 42 to 67. So this is moving really quickly. Just this morning, eating breakfast, I checked my phone and saw that one of the large pharma companies just acquired one of these theranostic companies for $250 million. Billions of dollars are being exchanged right now to acquire companies and try to advance these theranostic agents. So this is an important story for oncology, and it's going to be important for breast cancer. Now we're going to talk more about FES PET imaging for the time I have remaining. This is approved for a few indications. You notice that the approval doesn't mention lobular carcinoma specifically. This was approved first in France, and it's approved in France for known or suspected ER-positive disease. To my knowledge, it's not approved in other European countries yet. So a few key points with FES. We have to be aware of the pros and cons of all of our imaging studies. One thing with FES is it really is not intended to replace biopsy when biopsy is indicated. So uptake on FES doesn't necessarily mean you don't have to biopsy to confirm it. However, for areas that are difficult to biopsy, FES uptake generally is sufficient to be assumed that that would be disease. But if you can biopsy and confirm, we're supposed to. It's very important to think about what a negative FES PET scan means, because we always like to look at a negative image and say there's no cancer. But we simply can't do that with FES because by design it images ER-positive cancers only. So if a cancer was previously ER-positive but no longer is, we would not expect to see it on FES. Also, I have seen many ER-positive cancers, and we'll show one in the case discussion coming up, that I really expect I should see uptake and I simply don't, so it's not perfect, okay? A negative FES scan also does not definitively mean a patient will not respond to ER-based endocrine therapy. Again, I said I've seen tumors that are biopsy-proven highly ER-positive that haven't shown uptake. And so if there are other indications that the patient might respond to endocrine therapy, the FES scan should not override that on its own. We have some data on FES for lobular carcinoma. Dr. Uleiner has some data, others do as well. This is my study that we completed last year and published. And this was the first study, as far as I'm aware, that had a specific population of lobular breast cancer, biopsy proven at every site, where we were looking for initial staging of all comers for staging with FES PET. And what we saw, we really wanted to see how many of these biopsy sites are actually lighting up on the FES scan. And it wasn't 100%, but it was 83%, which is still pretty good, especially when our comparison is FDG potentially. And it was 88% on a per patient basis. We also saw additional lesions in the same breast and the other breast. Interestingly, a lot of those additional lesions we saw were not other sites of lobular cancer, but most of them were actually DCIS. And a lot of these patients had had breast MRIs and mammography and ultrasound that didn't show the DCIS until the FES scan showed it, and that's not what it was supposed to do. Nonetheless, we saw some breast disease as well that hadn't been seen before. That we went back, and in retrospect, you could find the correlate on an MRI and biopsy it, and lo and behold, it's DCIS. We also saw some extra lymph nodes, and in total, we found additional breast or axillary lymph nodes in 24% of patients with lobular breast cancer compared to their standard of care. Changed clinical stage in 18% of patients, which is in line with other studies where we think it might be about 20%. And it shows potential. This is not definitive proof. This was a pilot study, but it shows potential for lobular carcinoma for staging. We're now about halfway through a larger trial. We're going to report the mid-trial analysis at RSNA in Chicago, which is a big radiology meeting in December. I was part of a group that did a review panel paper on F18, including others that you may know, like Dr. Linden and Dr. Uleiner, who were here last year at this meeting. And I just wanted to point out that this is showing some strengths and weaknesses of FES PET. I hope you can see it there. But there's a few things. You can't detect ER negative malignancy, as I've said. You do have to have some washout period for patients who might be on endocrine receptor blockade, such as tamoxifen and fulvestrant, and that limits the utility of FES in settings where patients are on these. You have to wait to get the image. You have to take them off therapy for some time before you can image. And then you can still have false negative results in other areas as well as the liver and bowel because you have a lot of uptake at those sites. Bowel might be particularly concerning for lobular carcinoma patients because sometimes that is a site of spread, as we know. And it has also faced a lowered clinical adoption. There are many areas in the United States that cannot access this yet. There's still some lingering controversies and gaps in knowledge. There's some disagreement about how this should best be used. And there's still work to be done. This is showing the Society of Nuclear Medicine and Molecular Imaging appropriateness criteria for FES. And I just want to point out that staging lobular carcinoma is listed as may be appropriate, but not appropriate. This has indications potentially for insurance coverage because often insurance companies, at least very much locally, look at what societal recommendations are. So this also points to a need for more research with FES PET for lobular carcinoma because until we get this from may be appropriate to appropriate, I assume access is going to be limited. I'm going to show a few cases here. Saying time's up, but I think we're a little ahead of schedule. Can I take 5 minutes? Okay. So I just want to show some comparisons between FES and other imaging. What I'm showing here is that FDG PET, which this is, has a lot of false positive uptake, and this is really annoying when you're reading these scans, especially in the COVID era where people were getting COVID vaccines, which caused these lymph nodes in the armpit to light up on this case. This patient also had known granulomatous disease, which is a common cause of FDG uptake in lymph nodes throughout here. So she's being staged for breast cancer, and we're seeing all of the lymph nodes in the chest light up, and that is annoying, okay? Her cancer is here. FES doesn't have that problem. You know, on the FES scan, you clearly see the cancer. You clearly see that these nodes have no uptake because you do not have this reactive uptake, we call it, with inflammation or infection. This is a different case, initial staging, and similar to some other cases we saw, like with whole body MRI, sometimes FDG does show oligometastatic disease, like in this case, we have a mediastinal node and a couple ribs. But then you get more sensitive imaging and suddenly you realize there's more than 100 osseous lesions, and that can change management. That can be important information to know that even though this is technically stage 4 and this is stage 4, these are not the same stage 4, okay? This is showing rib uptake from fractures on FDG that we don't see here, but what we do see on FES is the tiniest little dot right there. And that little dot matters because that is a normal-sized axillary lymph node that looked normal based on every other imaging study, but FES clearly shows something's going on there, and I believe this was one where on sentinel lymph node biopsy, we saw that there was one node with positive disease, presumably this one. This is a different case where we see breast uptake on an FES scan and very clear nodal uptake here. The interesting thing with this lymph node is it was called normal on both ultrasound and MRI. And then we got the FES PET scan and had to go back. And this has become a new game that we're having to play in the FES era at our institution, is when we see FES show one lymph node light up, which lymph node was it? And so we try to use landmarks and where it is in the axilla to try to sort this out. And in this case, we guessed it was this one and we biopsied it and it was positive, okay? This is a case showing that sometimes our staging with CT chest, abdomen, pelvis has indeterminate findings, and it's really hard to know what to do with those. Maybe it's cancer, maybe it's not. We had this little sclerotic bone lesion in a slightly prominent supraclavicular node. And then on the clinical trial, we got the FES PET scan that showed this lymph node was cancer, and also there's way more in the neck and occipital region, as well as some bone metastases. And a lesion in the other breast. This hasn't been biopsied yet, but I'm guessing that will be cancer. Maybe it's ductal, maybe it's DCIS, maybe it's lobular. We'll have to sort that out. And there's the corresponding FDG, and it shows rib fracture here, but these other sites it didn't show. Another case showing extensive nodal disease that wasn't seen on FDG. And this case is interesting not so much for this bone met or this skin met here, but because it showed the leptomeningeal disease in the spine. And you can see the disease going through the nerve roots, the neural foramen. And I haven't really seen other PET agents to date show something this clearly in the leptomeninges. So that was a good case to show that this is potentially possible. And this is my last slide here. To me, this is very significant because this hints at the future of where we're headed. So this is a dotatate PET scan. This is a somatostatin receptor scan. We did not perform this for breast cancer, but we did this to evaluate a suspected carcinoid tumor of the appendix. It turns out she did not have a carcinoid tumor of the appendix, but the somatostatin PET showed all of this uptake in the breast, and it's kind of a diffuse pattern of uptake, which everyone in this room is going to be like, oh, that's lobular carcinoma. And so here's the same fused axial PET CT image. It was biopsied, it was lobular cancer. She got enrolled on a clinical trial. We got FES that showed the uptake and nothing else. You can see how difficult it might be to evaluate the bowel with FES, given how much tracer excretion you get into the bowel as well as the liver. We also got an FDG that did not show any of these areas. The thing I like about this case is it is proving that lobular breast cancer, at least in one case, has somatostatin receptor uptake. And why that matters so much is not that we want to image for staging with this, but we could potentially treat this cancer with somatostatin receptor therapy, which exists already for neuroendocrine tumors, okay? It just points at the potential proof of concept that these receptors are there. You could target them for therapy, and this could be a new way to go after treating this disease, in addition to all the other endocrine and chemotherapy agents that already exist. And with that, I'm done. Thank you.
So thank you very much for the 3 talks, very interesting. I don't know if you have questions in the audience? Yes.
Okay. Hi, this is a question regarding the full body MRI. And so if I'm lucky enough to get my doctors to give me one, or I have to go outside and pay privately and do it myself, how often do you recommend for a person who's been diagnosed with lobular to get one to see if there's any early stages of METs, like a year, 18 months?
So for the indication, you mean? We only do the whole body MRI in cases of locally advanced disease, so T3 or more, or N2 or more, in the case of primary setting, because I think it's not reachable to do it with every lobular cancer patient, unfortunately. But so mostly the locally advanced ones.
Just quickly, if say I got one, I'm in the US and there's a place in my neighborhood that offers full body, I'm not quite sure how much they are, but if I had one and then I present the results to my doctors at the university hospital, do doctors usually look at those, or because it's not their test?
I think there is a lot of variety in the experience of radiologists looking at whole body MRI. So I think you specifically need to ask at your own hospital if they are used to looking at those images. I had a discussion earlier. I think there, some radiologists are a little bit too scared, I think, because they are impressed by the amount of images. But actually, it's all the same sequences that they use for any other evaluation of other organs or structures. Like we do the T1 and the T2 weighted images, that is nearly in every MRI, and the diffusion weighted images also. It's just that it is the whole body. But I think if they are willing to, they can quite easily get familiar with it and use it for the evaluation.
Thank you.
I have a question for you. How long does it take to do a whole body MRI imaging? Is it much longer than a regular MRI?
For this indication for lobular cancer, it's about 35 to 38 minutes, which is really okay, because I think a dedicated MRI of the liver is also like 30-35 minutes. But now you have information about the whole body. It really is, we have, it's a screening method, so we don't have a lot of sequences for one part. For example, the liver MRI has also post-contrast images, and so sometimes we need to do an extra MRI to be more sure about one location or so. But for the screening method, which is, I think, I showed you that it's quite sensitive enough, but then we are able to keep it in a reasonable amount of time.
Okay, thank you. Thank you. Are there questions in the audience?
Yes, over here. Very, very exciting session. Matthew, I have a question for you. It's nice to see how it's progressed. We have tried FES PET in mouse modeling a few years ago, and I remember we didn't spend too much time on it, but we had problems because we have so much background in the liver and everywhere else, and it was very difficult in that little mouse to see anything. Could you just summarize what progress has been made? What's happening there in modeling, or in models, in vivo models, using FES PET for ILC studies? Or anything, actually.
Yeah, that's a great question. And you know the Whelms well at Huntsman, who do a lot of our model work. And we did have a study where we implanted mouse models. It wasn't breast cancer, it was actually endometrial cancer, because there was Jay Gertz, who you probably also know, studies endometrial cancer, and we implanted the mouse with FES, or with the tumor, and then imaged with FES and didn't see any uptake either. Our thought was that it's probably competition with the endogenous estrogen. Why we didn't see uptake. In your case, are you saying you couldn't distinguish it from bowel?
I think we had a weak signal, and I think we had a signal somewhere else, which I thought was the liver, or somewhere else. Bowel, might have been bowel, not the liver. So we didn't see a strong signal, yeah. Mm-hmm. So, yeah.
Yeah, but in terms of mouse modeling, I think there's a lot of potential, because there's one option to image an actual human with all of these tracers and see which one they might light up. There's another option to see if you can grow the tumor in a mouse and image the mouse with all the possible tracers that exist. And then you know from the mouse, like, this cancer's likely to show, you know, up with FDG but not FES, or, you know, maybe we do a screening for PSMA and somatostatin receptor, FES, transducer. Like, you could go through the gamut of everything that exists, image all of it, and then see the uptake. So I think there's potential, but there's not hardly any work that's been done there. However, I have seen other people starting to talk about this.
Yes, thanks a lot for the three great presentations. It was really fantastic. I have a question for Fresia. So it's really nice what you've shown, and I think it has great potential. And I think that, I mean, lobular breast cancer, as probably others, are a grateful, you know, pathology, also because of the different, I mean, the many differences they have to be detected by AI. Did you already do some work to see whether you could also distinguish different subtypes of ILC with that?
That's a fantastic question. Thank you so much for pointing this issue. So, in the work that we conducted, this development of an algorithm for diagnosis of ILC based on a genetic ground truth, we could detect classic ILC very well. But the model had challenges to detect ILC variants. And yesterday in the breakout session, we were discussing why is that? And it's probably because of the rarity of these tumors. They're rare in contrast to classic ILC. So perhaps the amount of cases that are included in a training cohort might not be sufficient to give the power to the algorithm. But collaborations can help overcome this. And the use of newer models, such as these new foundation models that are so robust because of their broad exposure, might require much smaller data sets for fine-tuning. So perhaps this is the solution to improve the diagnosis of these entities.
So the ones now, it's mainly to detect classic ILC that you do, and the others should be trained to recognize the solid ones, the other, I guess.
But I think that but I have to say that I have conflict of interests with IBEX, but as far as I know, the Galen-Breast algorithm could identify lobular, whatever they were, classic or variants, but not specifically to diagnose a variant of lobular, if you see what I mean. So it was not able then to say it's a pleomorphic or an alveolar. We have to train a model dedicated to that, yeah.
Can I ask one more very naive question to
Yes, sure.
Yeah, so it's actually to Matt and to Elke. So very naive question on my side. What is actually the minimum size that you could detect, you know, of a lesion, both, I mean, using, for example, FESPET and body diffuse weighted MRI?
The minimum size, you mean about 4 millimeters? We can go as low as that for lymph nodes. Yeah, even below that, 3 millimeters. Yeah.
Yeah, for PET scans, it depends on what type of scanner you have. When I was a resident, the common knowledge was 8 millimeters. Our newest scanner that we have has 2.6 millimeter resolution, I believe. And so it's each new generation of PET has a smaller resolution, but we're down to about 3 to 4 millimeters with the newest scanners.
Claire?
Hi, it's an AI question, because my understanding of AI is limited. I use ChatGPT occasionally. But my understanding is obviously it's the data you put in gives you the quality of information you get out of AI. And one of the things we've covered across the whole symposium is sometimes the lack of data we've got about ILC, and you mentioned it in terms of the subtypes. How likely are we to be able to advance AI quickly because we're missing ILC data and it's not being collected at times? And is there anything we can do as patients to help improve the amount of AI data you're getting to be able to put input into models?
Yes, fantastic question. Thank you so much. Yes, I think the advancements of technologies like the foundation models will allow us to develop methods that require smaller cohorts. We have not only that, we have also multi-institutional efforts and also public efforts, public initiatives that are accruing larger cohorts. And I think the technology is advancing in such a way that it's becoming perhaps much more weakly supervised or even unsupervised, facilitating the development of these systems with yes, the detection of the ground truth is becoming less and less important. And your very important question, what can patients do? And I'm going to quote a brilliant oncologist that was yesterday in our breakout session. I think you can continue doing what you do, which is bring attention to ILC and continue inspiring people and perhaps help generate funding so that all this research can progress.
I have a question for you, Frezia, regarding, to be sure everyone understands the difference between foundation models and the more classic model for AI. Foundation model, they use generative AI, is that it? Am I correct?
Yes.
So they use that kind of models like ChatGPT or etc. But so it learns easier, faster, and that's,
right.
that's it?
Yes. Yeah. So traditional models, they require, I mean, both have pros and cons. Traditional models requires a very large amount of data and a very strong and well-curated ground truth, right? So it requires a lot of expertise for example, if we provide a histology ground truth or perhaps a genetic ground truth, and one trains the model, it's like teaching somebody how to read, right? I teach a student how to read. Then that's the training part. Then tuning part, I sit with the student and I read with the student, read back this to me. Then I test the student. I give the student a book. Please read this aloud, right? Then I validate this. I give another book to the student. Read this other book that you didn't train with. If I am happy with the student's results, it learned really well, I can send the student to the library. And please feel free and read everything. But perhaps in the library, the student will find Shakespeare, will find literature in other languages, will find books where the font is in white, and the student was not exposed to this. So foundation models have this advantage. In foundation models, you give the student not a book, or you don't teach them how to read, you expose this to a lot of amount of data. So you expose the students to lines. When we learn how to read, we know that the letter D sounds like D, right? This will sound like A. But in a foundation model, you just give shapes, texture, forms, many different kind of information. And this foundation model learns by being broadly exposed to a lot of information. So this foundation model is very robust, but doesn't have a direct output. It's the foundation for other models that can be put downstream of this model that have a specific task. And these downstream models can be trained like traditional models, but in an easier way.
Thank you so much for this clear explanation.
I have a question for our two radiologists. So I kind of feel the same way about FES PET and whole body MRI, that they both have so much potential to be sensitive tests to detect cancer when we're not sure whether it's there, but we're still struggling in the clinic about longitudinal potential for these assays, these imaging modalities to look for treatment response. I'm sorry, I know this is a long-winded question, but you know, I wish I could have a shopping cart approach where I could use whole body MRI in the bowel, and then, you know, for lymph nodes or something, and then FES PET elsewhere. And it's like we have to compare apples to apples when we're looking for treatment response most of the time. So do you envision a time or a way where we could combine these two approaches to have one approach to, you know, follow treatment response? Who wants to take that on?
I'll start and then I'll hand it. So you could, in theory, do it already. PET MRI exists. I don't see any reason you couldn't use FES and get a whole body MRI with diffusion and combine the two. But I don't think anyone has done that yet.
That would be cool. Yeah, I think in the ideal world, it's a combination of everything. I always look at it like it's not a standalone technique, but you always have to combine all the information that you can gather. So the more information you can get, the better. But I think also regarding the cost and everything, that it's not ideal to do that in every patient. The combination might work, of course, but it's really important what you say about compare apples with apples. So if you start with a FES-PET, please keep it with that, because otherwise you get confused about is this a response or not. I didn't focus on treatment response in this talk because I did it in a breakout session, but whole body MRI is a really good method to do also the response assessment, and also in a more quantitative way where we can measure the ADC response. And so probably both are good techniques, and then you also have to look at the availability, maybe preference of the clinicians, I don't know.
Yeah, and just one potential problem with FES for treatment response is if you don't see the uptake, does that mean that it de-differentiated or that you treated it?
Yeah, I've seen a lot of clinicians say in progress notes it's FES negative, and therefore the patient is definitely, you know, endocrine refractory. So I'm glad you made that point. Is there another question?
Yeah. I just have an AI question. Do you think this foundation model could be able to detect subtypes of ILC that the eye of the pathologist, the even clever pathologist, would not be able to see? Can we find new ways of classifying ILCs?
That's a great question. It's a philosophical question also. I think the classification of ILC is evolving because of different technologies, and is evolving because of evolution of histologic criteria, incorporation of new criteria, perhaps refining of whether we will use this IHC or not, will this be required or not, and AI will perhaps also play roles in further refining the classification of ILC. In which ways, I still don't know, but we will see. Thank you.
Hi. Being a recent patient 9 months ago, I had to go through the staging process, which was quite anxious, you know, for me. And I had to go through a CT scan, an MRI, a bone scan, Okay. So listening to both of you and both these options, couldn't these be used for that, preliminary staging? Instead of having you know, to go through all these tests, couldn't you just have a body MRI, or not FES because we don't know, it could be ER negative, but can you have a body weighted MRI instead of having all these at the beginning?
Yeah, that would be a really good option. As I said, in our hospital, we do it only for the locally advanced, but as I also said, it's like a one-stop shop imaging method where all the information can be found. Of course, the standard of care is that you have optimal local staging. So you have the mammography and the ultrasound and the breast MRI. I don't think that we can replace that by the whole body, because there is still some extra information in the local imaging techniques. But for the staging, yeah, I personally wouldn't advise anyone to have a bone scan anymore. As I've seen those nice results of the whole body, but I'm a little bit biased.
I don't think you're biased. I was trained as a resident that bone scans are exquisitely sensitive, just so sensitive. And then we got choline PET and realized it's missing a lot of bone mets. And I'm speaking more for prostate cancer here than breast. And then we got flucyclovine PET, and we're like, oh, choline was missing all kinds of stuff. And then we got PSMA PET, and now we're like, oh, flucyclovine was missing all kinds of stuff. You don't know what you're not seeing until you get something better. I think we've definitively proven at this point that bone scan is not at all as sensitive as it was once thought to be. I just want to add, though, that for initial staging of an ER-positive lobular carcinoma, that's what my current clinical trial is trying to show, that actually you probably can use it for that. Yeah, you won't find ER-negative sites of disease, but for initial staging, most of those should be well-differentiated sites of tumor. So there's potential, but we still need to prove it with research, which I'm trying to do.
Do we have any other questions? No? So I think, again, thank you so much for this beautiful session, and we have a break now.
Okay, so don't run away. Now we're going to hear quickly from the different breakout sessions the short report about those. Because I know that, I mean, it was already for me, although, you know, I was designing also the program, but it was difficult to choose when we had these 3 parallel breakout sessions yesterday and today. So what we will hear now is that from each breakout session, we will have someone that will report to you in 5 minutes what has been discussed, what were the main challenges, and so on, so that everyone could have a good idea of what has been discussed. And so I will first ask to the person representing the pathology breakout session to come here. So Dr. Giuseppe Floris.
So I will try to be quick and reporting about our breakout session, which was very nice and lively. This is a slide that was prepared by Professor Brogi in no time, basically, and I will go quickly on the summary of each presentation. This was the presentation done by Stuart, Professor Smith, in which we learn actually how variable can be lobular carcinoma. We know quite well the classic type, but actually when we look at the microscope, we have to deal with architectural variants, with cytological variants, and maybe what is less known is the fact that from time to time these variants can be composite. We have also the so-called mixed ILC and NST, and this is a note maybe more important for the clinicians that tells us that this non-classic variant may be enriched of high-grade tumor, may be enriched of low ER expressing tumor and high expressing HER2 tumors. But are we talking the same language? This is a table that I prepared for another occasion in which we can see high variation even in the most common classic subtype of prevalence in the different studies. These highlight that the current guidelines are unclear and insufficient to capture this difference. So we need actually standardized criteria. So we came out with some action points, and we thought that the most relevant was the development of standardized criteria for the diagnosis of ILC variants. To this extent, we are starting actually tomorrow a very interesting study that we called Cadillac 2 under the supervision of Professor Vincent Salomon and Professor Schnitt, in which we are trying to improve the current criteria and provide recommendation for the recognition of the ILC variants, to improve awareness on ILC variants and validate their clinical significance. In the future, we hope to be ready to start also the Cadillac 3 study and to address the problem of the mixed NST and ILC. What about my presentation? Well, I highlighted just the usefulness of the immunohistochemistry with E-cadherin and cadherin, which works actually like an on-off switch in a majority of the cases. But we also understood that not all antibodies are made equal. And this difference is highly important whenever we are dealing with antibodies that are directed against the intracytoplasmatic domain of E-cadherin. And then we took our endeavor in the Cadillac 1 study to actually benchmark 5 different antibodies in which we could actually understand that the location of mutation in the CDH1 gene can explain some pattern of staining, but the type of mutation didn't actually influence significantly the overall staining performance. What was important to us was the combination of morphology and immunohistochemistry, and then we came up with our flowchart to standardize the use of immunohistochemistry in lobular cancer. So the action point here is very simple. We would like to see switching in the WHO book the criteria for the usage of immunohistochemistry from desirable to essential. And the discussion about this problem are going on just right now. And what is good to know is that in this symposium, at least 2 editors of the WHO are present, and this point was well taken. So the next point was the presentation of Dr. Gerudi. I hope that is pronounced correctly. Sorry, Lunas. So here it is once again to highlight that despite the fact that might not be so frequent, adding catenin staining can, from time to time, help in the difficult diagnosis of lobular carcinoma that might have higher expression of E-cadherin, especially in the presence of CDH1 mutation. This is once again to highlight the fact that the type of mutation, truncated mutation versus non-truncated mutation, can actually alter the pattern of staining, especially when we are dealing with intracytoplasmatic antibodies versus extracellular antibodies. And also very important was the finding and the suggestion that might be also important to look at the presence of mutation and prognosis in this lobular cancer patient. But although this is a first signal, this will be validated in the CANTO trial. So the action points, based on the genomic, we will need to understand the added value of molecular testing in the diagnosis of lobular carcinoma with ambiguous morphological and or immunohistochemistry staining pattern. And of course, we need to understand the prognostic and the biologic value of cadherin-1 mutation. I'm sorry, I forgot to put in italic, but this is a gene. And then, yeah, I don't want to spend too much words on this because we heard already the excellent presentation from Professor Pareja, and she explained very well that artificial intelligence may help us, but maybe we are not arrived at a point to capture all the morphological difference in lobular cancer, and these are the action points that were suggested. Artificial intelligence solutions for the diagnosis and study of histologic variants of ILC are necessary. We need to develop AI-based multimodal system for ILC and AI-driven prediction models for patient outcomes and response to therapy, and we need collaborative efforts for the integration of AI in the ELC diagnosis, and most important, we need also training program for us as a pathologist. And I see that the time is up. I want to thank you, and one last comment. Congratulations, Christine. It was a wonderful Congress.
Thanks a lot, Beppe. I think this was the fastest record to present 21 slides in 7 minutes, so very well done, and we got all the information, so fantastic. Now you can breathe again. Okay, so now I'm happy to welcome the representative of the session on imaging to present the report back on the session. Thank you.
Okay, in my biased opinion, the imaging session was great. We had some really good speakers and patient perspectives to start. This brought up some interesting points on imaging, and basically, I'll just say now the action items for all of this were essentially we need more research, okay? There are a lot of questions that we still have that we need to address. There's also a lot of really great technology that is here now and in the pipeline that we need to figure out more and get it expanded so that more people can access what we have. So as we've said a million times now this conference, imaging is not always super accurate with lobular breast cancer. We did talk about that. We specifically spoke a lot about response assessment on clinical trials and how patients are not able to get enrolled on a clinical trial because they don't have RECIST measurable disease, and that is an issue. We also talked about imaging with how does it fit into pathology, liquid biopsy. Often there's a lot of questions from the patient perspective tying everything together. Beyond the accuracy of imaging, other concerns exist. For example, concerns about radiation exposure, which I haven't mentioned on any of my PET studies, but the radiation exposure is high, it is. On one hand, we think it is safe level generally, but on the other hand, it's high enough that you only want to do it occasionally and only if it's really indicated. Even with CT imaging, sometimes there's concern or contraindications for contrast, and that's a real-life issue as well that plays into imaging choices. Even having an IV placed, a lot of patients, I mean a lot, like at least 10 to 15% we think on data, really can't tolerate MRI for no other reason other than it's claustrophobic. Breast MRI also has the special advantage that you're down like this with all of your weight on your sternum. I've understood that's extremely uncomfortable for a lot of people. So there's some real practical issues also just with the physical process of getting image that is not easy. A lot of variability exists in what imaging is available worldwide. And we spoke a little bit about MRI in freestanding clinics in the United States. That's a cash-only exam. There's a lot of current questions on, well, if you go to that clinic, can you then go back to your center and will they be able to get the images, reports? Are they talking to each other? So we didn't really have a lot of answers for that, but it was good for me, especially, to hear the perspective on all of those issues. And remember, it's about more than just imaging accuracy. There's a whole lot of other issues at play with imaging and how it relates to breast cancer care. We then spoke about the oncology perspective. This was also a really fantastic data-driven talk. We did speak about that the mammographic sensitivity is reduced with dense breast tissue and lobular breast cancer, but it still is part of our imaging strategy. Oncology perspective is definitely that false positives are important. I know that came up a few days ago, and that if we can find options where we're maximizing the benefit and risk of all of our imaging studies, that's ideal. Contrast enhanced mammography performance on many studies, and I've shown one here, does have sensitivity that approaches that of MRI. We don't have a lot of data on contrast enhanced mammography in the screening setting, but every diagnostic setting study that's been done really shows near equivalence. Most studies do show MRI is slightly more sensitive. On the other hand, many studies also suggest contrast enhanced mammography has fewer false positives. Just to kind of summarize that, it's pretty clear at this point that tomosynthesis is superior than 2D mammography, but the absolute benefit is still, in terms of cancer detection, roughly 1 to 2 cancers per 1,000 exams. And that you can do pretty accurate tumor response assessment for primary breast tumors with MRI or ultrasound. We then spoke about metastatic setting from the oncology perspective with imaging and response assessment. And a big question that was asked, and the answer is given here: can imaging be used to accurately predict treatment response in patients with metastatic lobular carcinoma? And the response is currently, I think the answer is no. So the action item there would be to work on that. We need quantifiable methods to accurately measure lobular carcinoma. Oncologists are seeing promise for FES PET as well as the future advent of FAPI PET. That is currently, I think, in my opinion, it's probably most advanced in Germany right now. The US is just kind of getting underway with FAPI right now. And we need more research. We then had a dedicated talk on neoadjuvant response prediction. And conclusions here are again that lobular carcinoma again poses a challenge in the neoadjuvant setting as well. We can go to the bottom. I thought this was interesting and something we're thinking about, that the pleomorphic subtype of lobular breast cancer tends to show up better on MRI than other subtypes as well, but that we need to be aware of all of this, and contrast-enhanced imaging is really key. We had a really fantastic presentation on whole body diffusion weighted MRI. And a lot of this was summarized better than I can do just an hour or two ago. I could just editorialize from my perspective. I do think that there's a role for this, and I wish more centers were doing this and trying to figure it out, because it's just another great tool to have available for patients. And for some patients, it can make all the difference, I think. And then we spoke on PET imaging, which we have 30 seconds left, so I'll just say, focus on the bottom here. We need to support ILC-specific imaging and theranostic trials. As theranostics and all these new PET imaging agents come through, it's important that we're advocating, these are mostly pharmaceutical paid studies, that they include lobular carcinoma patients, and that they will report on that data and not just group it together as breast cancer. And that's it from our session.
Thanks a lot. Stimulating and fascinating to hear about everything. So now I'd like to call the person reporting on the dormancy session to come and present to us. Thank you. Patrick.
Okay, we had a very interesting session on dormancy. It's going to be shorter than the other ones because dormancy is still a matter of philosophy in some respects. I'll just go quickly through the points we discussed. First of all, is the understanding of the biology of tumor dormancy. So I tried to give an overview of what we know about dormancy, what are the cues that induce dormancy, and what are the cues that sustain dormancy. The bottom line is that not a lot is known, and I will come back to that in a minute. Second of all, the therapeutic approaches for preventing and reducing the risk of relapse. We talked about that a lot, and in conjunction to that was the liquid biopsy techniques that can be used to detect or monitor dormancy and follow up with clinical measures. And finally, we had a long talk about the patient perspectives on the problem of dormancy, and is dormancy a problem or is it a solution? And basically we came up with the following, I can't read it like this, so I have to stand like this, sorry for that. The fundamental research on the models, the cues, and the clinical problem. First of all, we discussed what would be ideal models. And the problem with these dormancy issues is that all the research out there has been done on ductal cancer. So one question is ductal dormancy different than lobular dormancy? We simply don't know. We haven't done any research on lobular models, so we need to do that. And how do we do that? So do we need inducible models? Do we need lengthy models? Or do we need to, for instance, establish the differences between triple negative lobular breast cancer that doesn't show a dormant phenotype versus something that does show a dormant phenotype and is also ILC? So these are the things that are options for the future. We also talked about the models coming from the autopsy programs. Are they usable or not? The models that are out there, which are all metastatic disease, is that usable or not, or should we compare that to primary disease? These are things that are very unsure because we don't quite know what dormancy is at the moment. Oh yeah, and then finally, of course, we want to use, and that's a very strong point that has to be done, everything we find in models has to be benchmarked against the clinical samples to see whether we see the molecules that we identify in the models, that we see them in the actual clinical samples as well. So then the second portion was quite large. The presentations were about the clinical research that is going on to detect dormancy. And it was mainly focused on the detection of circulating tumor cells and circulating cell-free tumor DNA. And there also the question is, how much do you want to detect versus what is necessary in order to have a clinical intervention option? So in other words, do you follow active disease? And when does it start to be dormant disease? And where is that cutoff? How sensitive do you have to do your PCRing in order to pick up dormant cells versus active disease? And if you pick up something, do you know if this is dormant disease or whether it will never be a clinical problem? And for that, we need way more clinical studies to show retrospectively what is the association and the correlation between the presence of these CTCs and cDNAs, cell-free DNAs, to clinical responses in the future to be prospective in following clinical trials. Final thing in, and of course the standardization was an issue as well. So people have different ways to look at CTCs and DNA in liquid biopsies, and some pick up way more than others. And the standardization is still all across the board, as I understand from the people in the field. So this is something that needs to be standardized before going on to even discussing what is the threshold and how should we act upon that. And finally, we went into the patient perspectives. A lot of discussion was on what is the role of exercise, not in preventing maybe, but in sustaining a dormant phenotype or preventing relapse in the long run. We talked about the role of BMI, obesity, the intake of food and so forth, and exercise. We had some interesting talks, and I think Laurie had a very nice idea on yoga in order to sustain a healthy body and mind and soul in order to be as healthy as you can, basically. There was a question, and I don't know anything about this, are there any differences between ethnic groups in dormancy? I don't even know whether that's the case in irregular lobular breast cancer. There probably is, because there is in other breast cancers as well. I don't know if anyone knows this, but this is something that should be investigated as well. And there was an interesting issue by Elia that you have tumor biology and you have patient biology. And the two can be different, and this might be important in, you have to treat a tumor, but if you're looking at dormancy, you might be you have to think about influencing the biology of the patient other than the biology of the tumor, which might not be a problem, if you understand what I mean. So in other words, can we sustain dormancy in order to prevent actual intervention clinically? And this was something that was favored, I think, across the board with the patients, that it would be sort of an ideal situation if we would have a treatment that could sustain dormancy forever and not come up with an intervention technique, which is the case now. Now you have to wait until the problem arises and then hopefully understand why the problem arises, and then you can do an intervention strategy. And how cool would it be if we could sustain dormancy until the patient dies of old age? And I think that's the bottom line, and I would like to cling on to what the others were saying as well. We need way more investigations and research into what is dormancy, what are the cues that perform dormancy, what are the cues that awaken the dormant cells, which is the actual clinical problem, and can we either keep them dormant or tackle the awakened cells. Thank you very much.
So thanks a lot, Patrick. Yes, so still many open questions, many challenges. So now we will move to the metastatic breakout session. I think it's José Sandoval who will report for us. Thank you.
Okay, thank you very much. I would like to start by the end by thanking Christine for organizing this meeting that I think we all liked very much. Concerning this session on metastatic ILC, it was a session that was developed, I would say, really in group, taking the opinions of several intervenants, including two wonderful patient advocates, Christine and Julia. Thank you. I think you made this much better than what we were actually planning at the beginning. And we tried to focus on three topics that I thought were important when we think about metastatic ILC. The first one was liquid biopsies. So there was a presentation by me, maybe the most technical and probably boring of all of them, of the different types of what liquid biopsies, what do we measure, what are the different technologies to measure ctDNA, what are the limitations, what exactly, in which setting do we can use them. Then there was Rachel Yankovitz that taught us about which data do we have about liquid biopsies in ILC, the question is, there is data, but we need more, like everyone else in terms of research. And then we had Amanda Fitzpatrick telling us about liquid biopsies in tissues other than plasma. So if you think, for instance, about CSF or pleural effusions, ascites, and showing us her research and how useful it could be. After that, we went to the second topic by Christine that pointed out a second topic that we think is very important in metastatic ILC, which is actually awareness. Awareness of the clinicians, awareness of the public in general, awareness of the patients that ILC is different in terms of its biology, in terms of its clinical course, and of course, all the questions of diagnosis, all the questions of treatment and follow-up. The third point, which actually stemmed from a discussion with Julia and Christine, and focusing on a topic that they raised, which was the question of misdiagnosed or late diagnosis of ILC. And Adrian brainstormed with us and also with his team and trying to think of how can we actually describe its prevalence, but also how could we, in theory, in the future, use AI to actually mine electronic health records and help us prevent or reduce the amount of late or misdiagnosed of ILC. So my slides will focus mainly on the action points that we came after this session. And the first one is, no, it's not very original, but it's true. I think we need more research of liquid biopsies for patients with ILC. We need to prioritize studies that focus specifically in patients with ILC and that take into account the characteristics of the disease, of the biology, and of its natural history. The second point is we also should look at other fluids, other biofluids, not only plasma. And as Amanda showed us, actually profiling ctDNA in CSF could give us more insights about leptomeningeal disease, could help us probably detect it, and knowing that sometimes we can detect disease in CSF that we don't find in plasma. So we should not only be narrow-minded and think about blood and look at other biofluids. The third point, I think it's transversal to everyone, but very important in metastatic ILC, is that we need clinicians, researchers, and patients to be increasingly aware that ILC is a different kind of breast cancer with its own biology and clinical course. And we need to keep on pushing at every opportunity that we can to show that this has implications in diagnosis, treatment, and long-term follow-up. The fourth point is that we need to promote research on misdiagnosis and delayed diagnosis. And this is actually quite important and often mentioned by patients, as we've seen here. All the questions is like, did I have the right radiological exam at the beginning or not? Or did we miss my metastasis? What we just saw with the discussions about FES PET, that depending on where you are, you have access or you have different opinions. So I think this is also a big area of research that probably we should focus more on. And finally, I think that we need to do what we actually did, which is listening to our patient advocates that identified which points were actually more relevant to them and discuss which research we can do that focus on the points that are more relevant to the patients so that we don't lose focus of what actually matters. And I think these are our action points and a bit of a summary of our metastatic ILC session. Thank you very much.
Thanks a lot, José. And so we will move now for the session, the breakout session on the tumor microenvironment. And if I'm right, I think, yeah, it will be George Flemos explaining that to us. Thank you.
Okay, yes, so this was a super exciting session, very close to, I don't know, can you hear me? No. So it was very close to the dormancy and metastasis in terms of, we had the common conclusion that we need more research. That was very obvious for for all the participants. So we had the three excellent talks, and we had also the participation and the perspectives of the patient advocates. That was very insightful. And here I'm just showing a summary of the talks. So we tried to touch some of the hundreds of million components of the microenvironment. So starting from the immune microenvironment to the different reproductive factors, lifestyle and aging tumor microenvironment. This was the presentation from Professor Steffi Osterheid. And then the second was the role of fibroblasts in the immune suppression and the resistance to immunotherapy, presented by Professor Fatima Medha Grigoriou. And the third one, the last talk, was about the tumor microenvironment and the preclinical models that we have, lobular models specifically, presented by Professor Val Brunton. And we have a very interesting discussion with the advocates, as I mentioned before. So, so to go just briefly, just to give you an overview of the complexity of the topic, because the tumor microenvironment is complex, is dynamic, it's highly heterogeneous. It's not one, there are a plethora of different tumor microenvironments, and this has effect also on the therapeutic approach. So from the primary tumor to the metastatic site and to the circulation. So these are all different microenvironments that the tumor cells they experience. And it's not only about cellular component, but we also have normal cells that are involved or cancer-associated cells. So either fibroblasts, either macrophages, there are different types of cells. So we discuss for some of the cells and the data, existing data. And also we touch a bit the cellular components, what we call the extracellular matrix. So this is obvious that the tumor microenvironment is an emerging field. So here you see the overall increase of the number of publications, the last decade especially. And this is not for lobular carcinoma, this is for general, for all different types of tumors. For lobular carcinoma, there are not many publications in this field. So starting to briefly discuss the major points that we have some data to talk about. So what we know now today is that we know that overall there is a lower immune infiltration, but a relatively high proportion of macrophages in lobular carcinoma comparing to ductal carcinoma. There are increased specifically TILs in the pleomorphic versus non-pleomorphic ILC cases. That's interesting. Also, we try to understand how ILC respond to therapy. This is important. Also, we discussed that we need to target other immune cells than T cells, for example, cancer-associated fibroblasts or adipocytes, which also comes with the BMI and the fitness and the lifestyle, which is something that we need more research on that. So the second was the different ILC variants when we studied the immune infiltration and to design specific trials for the different variants. And obviously we need to further characterize the role of macrophages given the fact that we have the recent knowledge about the enriched in the pleomorphic ILC subtype. So so the second important point was the aging, the AIDS and the inflamed tumor microenvironment presented by Professor Steffi Osterheid, which was that ILC is diagnosed commonly in older women comparing to NST, and this is statistically significant. The inflamed aged tumor microenvironment causes immune dysfunction in older breast cancers, and most commonly associated with ER-positive tumors. And there is an increased risk with late age at first full-term birth and nulliparity for a lobular carcinoma. And also, there is a connection with a lactogenic, potential connection with the lactogenic gene expression that found in the lobular carcinoma comparing to NST tumors. But in general, there are limited clinical trials to study this further. So the second part was about the fibroblast and the role of this specific cellular subtype in the lobular versus non-lobular tumor, which there is definitely there is a difference in the tumor microenvironment between the two types of tumors. So specifically, there are data that presented by Professor Fatima that ILC is enriched in inflammatory CAFs, and not in the MIC-AFs, comparing to NST tumors. So there is a mechanism about that is proposed, that the lack of icathirin promotes the accumulation of the inflammatory CAF specifically. That brings also TILs, but however, at the same time, the lack of icathirin reduces the cytotoxicity of the CD4 positive T lymphocyte, and this is specifically for classic ILC. So we touched also about the modeling and the different models that are available. We discussed about the issue about the mouse models, that are most of the mouse models we use are immune deficient. So we need to move forward on that, either to generate humanized models or to use other methodologies like organoid co-cultures or organ-on-chips that are under development. And possible, we need to really target, and this is important, the tumor microenvironment extracellular matrix. This is something that there is no clinical trial and there are not so many targets. There are some data that shows that extracellular remodeling enzymes, they can be targetable, and that could make a difference given the fact that the lobular microenvironment is really dominated by a different composition of the extracellular matrix. So lastly, we discussed also about the modeling of the ILC and the interplay with adipocytes and the CAFs. And definitely we need to understand better and to model the response of lobular carcinomas to immunotherapies. And of course, it's important to model the metastatic tumor microenvironment with programs like the rapid autopsy program or the Hope for Others. So, and to study also the specific tumor microenvironment in the dormant microenvironment, the dormancy niche, what we call it. So this is all unexplored areas. And definitely we need to implement more clinical trials specifically for lobular patients to answer some of these questions. That's all. Thank you very much.
Thanks a lot, George. And now I think, Ellie, you will be reporting back on the last session for the hormonal and genetic risk factors. Thank you.
So I have one slide, so it will be quite quick. But just to tell you a little bit about what we spoke about. So we started off the session with Rianne and Esther giving us a bit of a brain teaser and also talking about the patient perspective, particularly focusing on families where there's 1 or 2 lobular breast cancer patients, but still no evidence of a genetic predisposition identified. We then, and Fabienne talked about her work, trying to study those rare variants and seeing if we could collect more families of lobular breast cancer to see if there really are any hidden predisposition genes that we haven't yet to identify. I talked a little bit about my work with polygenic risk score and common polymorphisms, and then we moved into discussing non-genetic risk factors. René gave a very nice discussion and an explanation about the biology that understands some of these hormonal risk factors. And finally, we had a rather lively debate about hormone replacement therapy. So I think the takeaway messages are there may be hidden genetic predisposition genes for lobular breast cancer that we have yet to identify, and we really need to collect families of lobular breast cancer, and one way to really help with that would be having an overarching ethical approval so that whatever country you're in, you could certainly link up with Fabienne, and she can, take this exome sequencing and whole genome sequencing forward, because we all have small groups of families that we know, but we need to put them all together to really make a difference. I think the other thing, particularly with this type of research, it's a lot of epidemiology, and we've got some studies where we've collected a lot of data on risk factors, hormone replacement therapy, and what we really want to do now is relate that to outcome. And it's quite difficult, certainly in the UK, getting through to NHS England, that this would be a very good thing for them to share data on outcome with us, obviously anonymised data. And so our patient advocates in the session felt very strongly that they could help researchers try and access that data and help us persuade government bodies to release that data to us. I think the other thing that everybody felt that there should be a lot more awareness of breast density in relation to breast cancer diagnosis and risk, and also HRT use. And following René's presentation, it was felt that we perhaps should be thinking a lot more about a personalised approach to prescribing HRT based on risk factors, but also a personalised approach to actually prescribing endocrine therapy. It's not a one-size-fits-all, 20 milligrams of tamoxifen. Maybe not everybody needs that. And I think the final thing when we talked about HRT was that medical professionals need to have a bit more training in explaining the risks of HRT. There's been a real move to kind of everybody having HRT, and perhaps some physicians aren't really thinking about other risk factors such as family history and breast density. But altogether, a very good session, and no one got too cross with me with the clinical perspective of HRT.
Thanks a lot, Ellie. So I think this was nice to hear back then from all the breakout sessions, to know what was happening in those sessions you were not able to follow. And so now, actually, I will take some time to thank everyone, actually, for this fantastic session. I hope that, like me, you feel like energized, that you feel inspired by the 3 days that we had together, possibly a bit tired as well, but I think that would be normal. If you would be worried that you had so much information that it's too much to keep in your head, don't worry. In a few days or weeks, we will be also putting the recordings, the presentations, the posters from the authors who agreed, obviously, to share those with everyone. That will then be on the website. If after a few days also you're nostalgic, don't worry, we will also put pictures there so that you can really feel again the atmosphere of the symposium. So there are really some people I would like to thank as well. So first, I absolutely want to thank very warmly the local team. So you may have heard about them. You most probably have seen everyone during this symposium. They may have chased the speakers for getting the presentation on time. They may have protected with their body, the gluten-free meals to make sure that the people who needed them, would have them. They have really made sure that the registration was going well, but also this was a lot of work actually in advance. And so a very warm thank you to François, Marion, Nancy, Karen, Hite, Josephine, and Beppe, and also Annie and Christine, who helped here a lot. So really, thanks a lot. And then I also want to say a very warm thank you to the other members of the scientific committee. So Patrick, Anne, Philippe, Steffi, Rita, and Rachel. Because together we tried to make really the best out of it, to try to think, what would be interesting in terms of program, because obviously we are still on I think, a curve which is going up, but we are still on a learning curve to try to make it every year better for everyone and for all the communities. So thanks a lot to them as well. And then, as you noticed, this conference, this symposium is very special, very particular, So I really would like to thank also very strongly the patient advocates, which were real partners in designing, in deciding about some sessions, and also, as you may have seen, in all the preparations that we had to do, you know. And I think that that's something that maybe most of you felt, you know, that it's not just the symposium was not just these 3 days, but were all the months beforehand that we had, and that we had all these very interesting discussions and meetings all together. And we have more, and we have so many more advocates which are not here on the picture or were not on the website, but were helping so much, giving so much of their person, their expertise, enthusiasm, and opinion during actually the conference. And then obviously also I want to say thank you to the speakers, the presenters, the chairs, the moderators, because I think we often also ask a bit more from you than in regular conferences, you know, so it's not standard that for this symposium you have so many preparatory meetings, so really thanks a lot. I know we asked a lot, but I think that that was also the richness actually of the sessions, to make sure that especially for the breakout sessions, you know, we were thinking beforehand what we wanted to reach, what we wanted to convey, what would be most interesting for the community. So thanks a lot to everyone. And then also thanks a lot to the sponsors, because otherwise it would not have been possible. So thanks to the Breast Cancer Research Foundation, Exact Science, the Dynami Foundation, the Labular Breast Cancer Alliance, Daiichi Sankyo, AstraZeneca, the Cost Action from EU, Menarini Stemline, Lilly, and Agendia. So really a big thank you also to all of them. And finally, a huge thank you to all of you. So this is the picture, you know, we did when there was a bit of sun outside. So really thank you, thank you, thank you, because a symposium only works when everyone's, you know, is motivated to attend, to participate, to ask questions. You know, the questions, the discussions, that also what's making the symposium a success. And so we hope really to see everyone in 2 years from now. We decided that it would be in 2 years because we feel that now we have a lot of work that we need to do back, everyone, on the side of the clinicians, the scientists, also the patient advocates, because it has been a very intense period for everyone to prepare this symposium, and now we need all to go back. We need to do some good work, and then in 1 year from now, we'll start preparing the program based on all the recent advances to come back even stronger, to show what we have done, to impact, you know, on guidelines like we've seen, you know, for pathology, like maybe we want to do with imaging and so on. So I think that our community is growing. We had this beautiful, I think, very warm atmosphere here, and I thank you all. Thanks a lot.